Well, thanks, Brett. It's a pleasure to be back. And unfortunately, we'll talk about an equally bad problem here without equally good solutions, as we just saw with the pilonidal disease. But I think it's important, if you're in a colorectal surgical practice, these patients will come to your office. They will be quite miserable, and it's helpful to have a bit of an organized approach. I don't have any disclosures for this, but the disclaimer is that the evidence under this subject is absolutely awful. I think it's not the fault of the people that are trying to fix the problem, but it's just not a very common problem. A lot of things have been tried. So I think I'll present what is good today. If you have a better way to fix this, then please publish it, report it, and show us a better way to do it. So what I'm going to talk about a little bit today is just a patient walks into your office. How do you recognize this problem? A lot actually, about what not to do for this, because there's some crazy solutions that have been proposed out there, and hopefully get into a little bit about what to do. This was a topic that came up to me as part of, I was working on the ASCR's Clinical Practice Guidelines Committee. We decided to write a guideline on this because there really wasn't much out there. And the interesting thing, looking at the list of visiting professors today, this was actually assigned to George Chang, and he was too busy curing the world of cancer. It got kicked down to the lower man on the totem pole, so I can thank George for learning everything I have about radiation proctitis. But this is what it's going to look like when you scope one of these patients. The rectum is quite friable. You have all these vascular malformations and telangiectasias in the rectum, and they come in with a lot of symptoms. I'm talking more about the chronic presentation. A lot of patients will have some acute proctitis during treatment. I'm talking about the patient that comes back to your office later, and they're very identifiable. They have hematochezia. They have some mucus discharge. They've really lost the compliance of the rectum from all the radiation, so they come in with things like tenesmus and sometimes even fecal incontinence. If you look back at the data over time, fortunately, this is a less common phenomenon than it used to be. I think we've gotten better at delivering external beam radiation, but I think we're not perfect at it. I'm taking care of a lady right now that has problems far worse than what I'm talking about today, all from radiation damage from anal cancer. So I think if we're in practice and we're seeing these patients, they will come in with this presentation. I think when they come in, the patient has nondescript symptoms. They're bleeding. They're having some of these symptoms. We need to keep a differential in our head, but it's important to remember that this person had a cancer of some sort, and we need to review that cancer history, see what type of cancer they had. It's helpful to review the radiation history, and if nothing else, in your differential diagnosis, you have to rule out a recurrence of that primary cancer. Could this be a recurrent anal cancer or a prostate cancer eroding into the rectum? I'm certainly not going to treat that with topical agents. Obviously, a proctoscopy in the office, that's often enough in the right clinical history. I would do a full colonoscopy if it was indicated. That would be the setting of, I can't quite see up to the top of the distribution of the disease, or if the diagnosis is in doubt, we need to get a better clinical picture. Usually with the right clinical history and the right findings, you don't need to biopsy this. You can put a diagnosis together and start treating. I'll talk a lot about what not to do, and I'll try to summarize it as briefly as possible. But the short story is, when we did the literature search for this project for the ASCRs, there was a litany of things in the literature that were all case reports and things that just don't seem to work. So here's what hopefully not to waste your time on. So the first thing is, I think the way to prevent this is to use better techniques with radiation. People have written a lot about trying to do surgery to prevent radiation proctitis. Bad idea, don't do it. So don't use tissue expanders, don't use omental flaps. It's just not going to work. We had a young lady at our institution. We did try to do something like this. That we had a patient with a pouch that needed pelvic radiation for a gynecologic cancer, and we tried to do all this stuff, and it didn't work. She still had really terrible problems with the pouch. So you can't prevent this other than just using good radiation techniques. Some of the compounds, people talk about short-chain fatty acid enemas and things like that. That tends to work okay if you have a diversion proctitis. It's not going to work for a radiation proctitis. So I would skip those type of treatments. Some of the other alternatives, I put it into a broad category here. People have tried things like mesalamine, ozone therapy, metronidazole. None of these things have been evaluated. The literature is actually quite weak, and I would skip those as well. And the last things to skip I would put in as sort of a procedural group. People have talked about all kinds of endoscopic techniques using different radiofrequency ablation, different laser techniques. None of these things really have very good evidence at all. It's a little bit different than APC, which I'll talk about in a moment, which does have some evidence. But none of these things have great evidence. And if you have good experience with anything I've talked about, then publish it and change the evidence that's out there. So I'd like to close with a few treatments that actually do seem to work. And again, this is based on weak literature, but this will hopefully give you a place to start when you see these patients. We'll talk about a couple medical therapies and then a couple other things that you can do if those aren't quite working. The first thing that is probably the easiest thing that you could try is to use either a Carafate or a sucralfate retention enema. You can get this made at any compounding pharmacy. There are lots of different compounds that have been made of that, but usually a 2-gram solution in 20 milliliters of water, and the patient takes an enema twice a day. I think if you have a patient with mild proctitis with some bleeding and they're relatively compliant and you can get this compound, it's relatively easy to use. A little bit about expectation setting when you're treating these patients, though, and I'm going to go into this on a few of the slides. It's important to set the expectations. Almost any of these treatments that I mentioned will help with the bleeding, but these patients have a lot more going on than just bleeding, and it's not going to help as much with some of those other treatments. So you can see here all small series, but relatively good resolution of bleeding with these topical compounds. When you look at another small study as well, they looked at a composite outcome. So they said, we're going to take these patients with radiation proctitis and look at a composite outcome. Did they improve in bleeding and urgency and frequency and tenesmus? And it turns out that the bleeding got better in those patients, but as far as fixing all of those symptoms, they had a partial resolution in 40% of the patients and a complete resolution in only 30% of the patients. So I think it's important to set the expectation up front, find out what's bothering the patient. We can fix the bleeding. We can maybe help some of these other symptoms, but I think once somebody has lost that compliance and has a lot of damage to the rectum from radiation, you're not going to make them perfect again, and it's important to explain that to them. The other treatment that does seem to work, and this is what I have probably used the most, I would say this has probably been the most used treatment for decades, would be topical Formalin. People describe anywhere from a 4 to a 10% solution, and I've tended to use 4 in my practice, and it's worked fairly well. Again, relatively good data for bleeding cessation, as all of these treatments have. There's a little bit of evidence in the literature that if a patient has very severe proctitis or if they're on particularly antiplatelet agents, you may need to retreat them over time to get a full result. There are some case reports. Obviously, these are toxic substances, and people can get rectal strictures or fistulas. I think this would be, if you grossly misuse the product, you may be likely to get something like that. But it is a treatment that can be used quite effectively. So I would say probably reasonable with mild bleeding. With a compliant patient, you may try the topical sucralfate. Formalin, though, is quite effective in a more severe case. Probably the only other thing that you, the surgeon, can do for this would be to try to treat it with APC, and there certainly is some evidence out there. I think you have to be a little bit aware of selection bias in the literature, because it seems to be that in most cases the more severe patients went and got an endoscopic solution, whereas the patients with a simpler problem had just topical compounds. But we see, again, reasonable cessation of bleeding. Most patients need a few sessions, and I think that's a reasonable thing. If I'm personally treating this, I would rather be a little bit more conservative about it and have to treat it a couple of times than go down and try to over-treat it and really overburn and over-cauterize the rectum. And that's when you start seeing these reports in the literature, some scary case reports as full-thickness injuries and perforations, and I think that's when somebody just got a little bit too aggressive with the problem. One comparative study, literally one comparative study, where they compared APC versus topical Formalin. And if you show there, I've got the red box on the slide. It essentially shows that whichever treatment you picked, the bleeding tended to get better, but the other symptoms did not tend to get better. So just kind of backing up that theme that I think is worth repeating. The last treatment that has been described, I've used this in one patient, it is hyperbaric oxygen. There certainly is a reasonable amount of evidence about it out there, but you have to think about what you're asking the patient to do here. It's an expensive treatment. Most protocols require many treatments, up to 40 sessions on average. The bleeding does tend to get a little bit better. I think this data is a little bit skewed as well, because these were sort of end-stage patients that had a really bad problem that came for hyperbaric treatment. The patient that I chose to use this in, we had somebody we couldn't get a resolution using anything else, and they had a lot of ulceration of the tissue, and over time they did heal some of those ulcers and at least get back a little bit of quality of life. But I would recommend using that as a line of last resort. So hopefully, in summary, keep an adequate and broad differential diagnosis in mind. Remember that these patients did have cancer, and you should prove that they don't still have cancer, and you're not missing the diagnosis. I would definitely go to the medications first that I had mentioned, the sucralfate or the formalin. APC is reasonable and something that you can do as a surgeon. It's not a hard technique to master it all. And for some of those tougher cases, hyperbaric. But I think this is an area where we need a little bit more help than even this. Thank you.
Thank you very much, Ian, for a very nice summary on a difficult topic. Are there any questions for Ian before we switch over?
Great talk. But I have a question. When you apply the formalin, how do you do that? How long do you apply it?
Yeah, there are lots of different ways to do that, and I think if you have an approach that works for you, that's reasonable. You can do it in the office or in the OR. I tend to do this under sedation in the OR. Basically, I can apply it a little bit more focally. I tend to use liberal use of those very large procto swabs that you can soak in it and focally apply it. I don't watch a timer or anything, but I sort of keep it on there long enough to treat each spot that I'd like to treat, and then I usually wash it out afterwards before we leave the OR. I think you get into trouble with some of these complications with strictures and perforations when people are just pouring the substance all over the tissue or spilling it onto the perianal tissue or not washing it off adequately. You want to treat the problem, but you don't want to leave a toxic substance on there long enough that it's going to cause new problems.
All right. Thank you very much, Ian. So